Dear friends and colleagues, I would like to welcome you to our 2020 Uveitis update. And it's my absolute pleasure to welcome my friend and mentor throughout my residency and fellowship, Dr. Gary Holland from the Stein Eye Institute, UCLA. He's going to serve as the moderator and the speaker of this session. And he will be joined by an esteemed panel, Dr. Edmund Tsui, a rising star in uveitis, also an assistant professor at the UCLA Stein Eye Institute, and Dr. Scott Whitcup, a clinical professor of ophthalmology at the Stein Eye Institute at UCLA, but up and foremost, a well-known clinician and scientist, well-known in research and development of drugs and medical devices. It's a real pleasure for us. I know that it's very early, LA time. So, Gary, the floor is all yours.
Thank you very much. I really appreciate Dr. Chironis's inviting us to join you in what I guess is this evening for you.
Right.
I wish we could be there in Athens together, but alas, I'm speaking from my office on the UCLA campus. I do so on behalf of the entire UCLA uveitis service. And one of the advantages of a virtual meeting is that I've been able to include a couple of my colleagues that Dr. Chironis introduced, Dr. Edmund Tsui and Dr. Scott Whitcup, who will be speaking with us later during a discussion section. First, my disclosures. I have no conflicts of interest with this presentation. I will discuss off-label use of some medications, and that's because there are very few drugs approved specifically for the treatment of uveitis. We'll review Dr. Tsui's and Dr. Whitcup's disclosures before the discussion section. So here's how I've organized this session. I'm going to start by reviewing some topics of interest that have been under discussion over the past year, both at the recent American Academy of Ophthalmology meeting and in the literature. I've listed them here. They're all clinically relevant for a general audience. We'll follow that with a panel discussion in which we'll go into more depth about some of these topics, and then we'll end in a question and answer session moderated by Dr. Chironis. First, I want to say that uveitis is a dynamic field. It's continues to grow. In the past year, as you see here, there have been over 1,000 articles written specifically regarding clinical studies of human uveitis, and it continues to increase. Some of you may be familiar with the Web of Science, which is a means of looking at various metrics related to articles that have been published. And as you can see here, the Web of Science shows that many of these 1,000 articles have come from Europe, as demonstrated in this graphic. And I'll be highlighting various articles from around the world during this presentation. So let's start with the first of the topics I wanted to present, and that deals with ocular toxoplasmosis. I understand from Dr. Chironis that ocular toxoplasmosis remains the most common cause of posterior uveitis in Greece, as it is in the United States and worldwide. One of the problems with toxoplasmic retinochoroiditis is that patients are at risk for recurrent episodes of active disease, as shown in this sequential series of pictures from one patient. You can see here that a patient has a recurrence from a previous scar. And with this episode, at least, the fovea is uninvolved. But with additional recurrences arising from that previous recurrence, the fovea has eventually been destroyed, resulting in major vision loss. So for many years, a goal has been how to prevent recurrent disease. Especially important for a patient like this who has congenital toxoplasmosis with bilateral macular scars, yet retains reasonably good vision, especially in the left eye. Almost 20 years ago, a study was performed in Brazil in which patients were continued on intermittent trimethoprim sulfamethoxazole after resolution of an episode of toxoplasmic retinochoroiditis. And as you can see here, there was a reduced risk of recurrences during the 20 months of therapy that the patients were on treatment. But a question is, how long lasting is this effect? Or how long should patients be continued on such treatment? About the same time, I participated in a study with researchers in the Netherlands, and in fact, Dr. Chironis assisted us with this study that showed that although the risk of recurrence decreases over time, it doesn't go to zero. So this continues to be a subject under study, and I wanted to highlight an additional article from Brazil in which a similar study was performed in which patients were randomized to every other day trimethoprim sulfamethoxazole versus placebo for about a year, and then they were followed for up to 6 years looking at rates of recurrence. And as you can see from the results here, those on trimethoprim sulfamethoxazole had no recurrences until very late. There was one recurrence out here at six years, but a much higher rate of recurrence among those who hadn't received that additional year of treatment. So a question that I'd like to pose to our panelists is, how long should treatment be continued? And who are the most appropriate candidates for treatment? We don't want to just treat everyone because although the rates are small, there is some risk of side effects from the treatment. The next subject I want to highlight is the use of imaging to quantify intraocular inflammation. And here I've shown a poster from the recent American Academy of Ophthalmology meeting from the Cleveland Clinic in Ohio, in which Sunil Srivastava showed that the use of anterior segment and posterior segment OCT and artificial intelligence analysis of fluorescein angiograms could show a response to anti-inflammatory therapy over time. This raises the possibility that we can objectify the assessment of inflammation and its response to treatment in monitoring our patients and in developing new drug therapies. This is an area of research around the world, and I've pointed out one article this one from China in the American Journal of Ophthalmology, that addresses some of the important issues that need to be studied. Those include standardization of the results across different imaging platforms, validation of results against clinical outcomes, and how best to implement the use of imaging techniques in clinical practice and in clinical trials. One of the things that they showed was that anterior segment OCT could identify cells in the anterior chamber, and it correlated with the semi-quantified categorical data that we have traditionally used clinically. But our goal in using imaging techniques is actually to be more precise than these clinical categories, using a continuous scale, which may allow us to see more subtle changes at the lower levels of inflammation that are common in people with anterior segment uveitis. Dr. Tsui is very involved in this line of research. This is an image from his studies showing that anterior segment OCT can identify cells, some of which are pointed out by the arrows, as well as keratic precipitates on the back of the cornea. And during the discussion section, Dr. Tsui will deal with some of the technical problems in developing these objective techniques for clinical use. Another topic of intense interest currently is the use of big data for the study of uveitis. Big data being the use of massive data sets which allow us to study problems that are not sufficiently common, that we can do studies at single sites or with small data sets. Big data allows us to identify changes and make discoveries that wouldn't be identified with small patient populations. Again, from the American Academy of Ophthalmology meeting was this presentation by Jennifer Thorne from Johns Hopkins University, in which she studied cataract surgery outcomes among people with uveitis using the IRIS registry, which is a collection of patient information maintained by the American Academy of Ophthalmology that includes information from millions of patient visits. Using the IRIS registry, Dr. Thorne was able to study 47,817 cataract surgeries among 32,734 patients with uveitis. And she was able to show that almost 83% of them achieved 20/40 or better visual acuity at 3 months post-op. And that's comparable to surgical results among the general population, 83.5% of them achieving 20/40 or better vision in the IRIS registry. She's going to continue to use this data set to look at predictors of better outcome or risk factors for adverse events in those 20-some% of patients that actually do have complications. Studies like this are going to be important in developing the best techniques for doing cataract surgery on these higher risk patients who have uveitis. Here's another example of using big data for the study of uncommon events. This study, which is in press in the journal Ophthalmology, was performed by some of my colleagues, and it studied the uncommon but very important side effect of cancer therapy using the new class of agents that we call checkpoint inhibitors. Some patients on these drugs will develop uveitis. It's uncommon, about 1% of patients, but it can be devastating when it occurs. And using the iris registry, Dr. Sun was able to identify the precise incidence of this problem. She was able to confirm that these various episodes of uveitis were associated with the drugs as suspected, and also the important point that patients who already have uveitis and are being treated with these cancer drugs are at a substantially higher rate of recurrent uveitis than other patients using these cancer therapies. So this is important information for all ophthalmologists who may encounter their patients who develop cancer and are undergoing this increasingly common therapy. You need to be aware of the possibility of this side effect, although it's rare, and be particularly aware of it in your patients if they already have uveitis. In our discussion section, Drs. Tsui and Whitcup can discuss some of the approaches to treatment of this side effect, both locally and systemically. Important in the management of uveitis, of course, is immunomodulatory therapy. A lot continues to be written about the use of immunosuppressive drugs because of all the new agents that are being developed. And I want to highlight one article from Italy in the journal Ocular Immunology and Inflammation, which is a journal that general ophthalmologists may not see on a routine basis. And this particular article deals with adamantiasis Behçet disease, which is certainly more common in Greece than it is in the United States. The purpose of this very small non-randomized study was the authors wished to show that choice of agents based on clinical findings could be associated with good outcomes. But this particular figure from the paper caught my eye. It actually compared the risk of relapse during treatment between patients on infliximab, which is an anti-TNF agent, and interferon. It showed that relapses occurred earlier in those on infliximab. Infliximab is probably the most common immunomodulatory agent that we use for all forms of chronic non-infectious uveitis. And in this particular study, patients were being treated with 6 milligrams per kilogram per infusion every 6 to 8 weeks. An important point that I'd like to leave you with is that we know from experience that patients with uveitis usually need higher doses of infliximab and at shorter intervals between infusions for effect. And we also know that over time, patients need to have dose escalation and perhaps even shorter intervals down to every 4 weeks to maintain control. This may be in part related to the immune system developing antibodies against this monoclonal antibody. So the take-home point is that if you have patients on infliximab, you need to be monitoring them closely for loss of effect and escalate therapy to regain that control. As a final topic, I want to discuss quality of life among uveitis patients. Increasingly, we need to consider a holistic approach to patient care. We want to consider the impact of disease and the treatments we administer on patients' quality of life. There have been a number of studies recently looking at quality of life among people with uveitis. This is one study also from Ocular Immunology and Inflammation, this one coming from China, that investigated anxiety and depression among people with uveitis. It did so using a variety of questionnaires, one of which is the VFQ-25, which you may be familiar with, the visual function questionnaire that looks at vision-related quality of life, but they also used the hospital anxiety and depression scale. Here are a couple of figures from their study, and they showed that there was a correlation between anxiety and vision-related quality of life and depression and vision-related quality of life. They showed a number of risk factors related to those psychosocial problems, including, not surprisingly, poor vision, but also people with lower annual household incomes and those with complications of disease. Another point is that although there is a statistical correlation, there's a broad spread of data points in these plots. So some people will have much more anxiety or depression at different levels of vision-related quality of life. Patient-reported outcomes like this are increasingly included in clinical studies and in drug development. And an important point to keep in mind is that we need to use multiple different scales, not only looking at vision-related quality of life, but general health measures as well. There's a study that came out of the Netherlands that showed that reduced quality of life persists into adulthood among children with uveitis, even with good visual acuity. And so with that introduction and background, I want to turn to our panel discussion. And first, here are Drs. Tsui's and Whitcup's disclosures. And I've listed here a number of topics that the three of us can discuss, and we will get through as many of them as we can. So I think you can probably see on the screen Dr. Whitcup and Dr. Tsui. So welcome and thank you for your participation. One of the things I'd like to start off with is the COVID-19 pandemic. It's certainly on everyone's mind. It's why we're conducting a virtual meeting. And actually, uveitis is not a manifestation of COVID-19. Some patients do get conjunctivitis, and some get vascular problems, including retinal vascular problems, but intraocular inflammation has not been a reported problem. But it does have implications for the management of our patients who are on immunosuppression for treatment of uveitis. So I'd like to ask Dr. Whitcup his thoughts about managing immunosuppression among people who are at risk for developing coronavirus infection. And that may lead into a discussion of vaccines and their relationship to uveitis. So, Scott?
Well, first, thanks to the organizers for the invitation and to Gary as well. Two other disclosures that weren't on the slide. One, I'm half Greek. And second is my Greek is horrible. Many of you know Dr. Grigudis at Mass Ioneer when he would always say, yes, which half? The good half is Greek, the other half we don't care about. But it's a pleasure to be lecturing, although I wish I were, as Gary said, in Athens with you. I think managing patients in general has been difficult during the COVID-19 pandemic, but especially if you have patients on systemic immunosuppression. And I think as ophthalmologists, we have a couple of challenges. One, it's difficult to assess ocular inflammation by a teleconference or a Zoom call. Some of the other fields in medicine can ask patients how they're doing. The therapy is based on how their joints are or how they're walking. With us, our treatment parameters tend to be how many cells in the anterior chamber, what does the vitreous look like? So I think this has been an added challenge. I think the best you can do is if patients have any symptoms, unfortunately they need to come in. In terms of managing the immunosuppression, I think what's helped, at least in the United States, is a lot of the monitoring is based on laboratories. You want to make sure that for patients on systemic immunosuppression, that their blood counts, electrolytes, et cetera, are within the range that you want them to be. And at least in the United States, you've been able to send patients in a safe manner to at least get laboratories drawn. So I think in the absence of coming to busy clinics or hospitals for visits, monitoring those patients by not postponing laboratory assessment has been an important piece of that. So again, any change in vision, symptoms, they need to come in because we make treatment decisions based on inflammation in the eye. But if they're on systemic immunosuppression, make sure that you don't postpone obtaining laboratory values and follow those closely.
One question that often comes up is, should the patients stop their immunosuppression? We do not do that, but we do want our patients to be very careful about infection control guidelines, masking, physical distancing. Do either of you have other thoughts about that?
Yeah, Gary, again, thanks to the organizers for the opportunity to speak today, and thanks for the invitation. I think, as we all know, with COVID-19 pandemic and the management of uveitis patients, we've encountered, several obstacles, especially Dr. Whitcup had mentioned regarding visits being unable to be performed on telehealth. I think one of the approaches that we have is the benefit of having local treatment. So for patients that we're not sure we should escalate immunosuppression at this point, we could potentially use dexamethasone implants or other periocular steroid injections. And I think this was some of the earlier approaches that we had in the beginning of the pandemic when we weren't sure what the effects of immunosuppression would be in patients with COVID-19.
Probably the greatest risk, of therapeutic risk for patients is if they're on high-dose systemic steroids or alkylating agents like cyclophosphamide. But patients on biologics are generally not, their management isn't changed. But yes, we do worry about escalating treatment. And another thing, another strategy that I've employed is even if patients are doing well and they may be scheduled for some tapering of their medications, I try not to make a lot of changes because that would call for the need for more frequent visits. And I'm trying to limit patients' need for coming into the clinic and the hospital. We're all anxious for vaccines, but there are some thoughts about vaccination and uveitis, and not just coronavirus vaccines. I'll just say one thing, and that is that if you have patients with uveitis, regardless of the kind of vaccination they're getting, they may have a bump in their intraocular inflammation as you stimulate their immune system. But I think Dr. Whitcup has some additional thoughts about vaccination.
Yeah, I think, as you know, we're about to embark on potentially vaccinating several billion people. It'll be interesting, maybe big data will help us see what the real risk is, as Gary said, for stimulating autoimmune disease with vaccination. It makes sense that if you're upregulating the immune system, that someone either with underlying autoimmune disease or who's prone to at some point getting autoimmune disease might develop manifestations of that disease post-vaccination. Interestingly, autoimmune disease following vaccination is very, very rare, but does occur. And mechanistically, you could see why. Just a couple of thoughts. I had the opportunity this last week to go through the Pfizer data. Many of you in the audience, I'm sure, have family members asking you, should I get, the vaccine? I went through the Pfizer data, and as you heard, efficacy is quite good. It prevented new infection in probably 95% plus of patients. And safety-wise, besides the local effects, was pretty well tolerated. Interestingly, there were 4 cases of Bell's palsy in the vaccine group and 0 in the placebo group. Now, the manufacturers went on to say that's about the background rate. They expected about 4 cases of Bell's palsy. But the fact that you had 4 cases and 0 cases raises the possibility, are you stimulating some autoimmune disease in the vaccine group? Would those patients have eventually developed Bell's palsy or some autoimmune disease? Who knows? My approach has been, infection will also stimulate the immune response. So to think that if you don't get vaccinated, you're protected about getting an autoimmune disease is probably false. If you get COVID-19, it's going to stimulate your immune response. Maybe you get the same rate of autoimmune disease. That's one. 2 is, you probably don't want to immunize someone who's having an active flare-up of their disease. So my approach always has been, if a patient comes to me and says, I have uveitis, can I get vaccinated? Make sure that they've been stable, they're on a stable range of anti-inflammatory therapy. Then I think in most cases, the risks of disease outweigh the risks of vaccination, given that it's so rare. Practically, most of the cases, if there is an association between some type of immune-based disease and vaccination, it comes within 1 to 2 months. The advisory committee for FDA reviewed just post-vaccination inflammatory disease, and there's been, in their review, only 1 case of a long-term autoimmune disease that they thought could be related to vaccination. That was following a live polio vaccine. So if you see exacerbation, it's usually within 1 to 2 months. So you can tell patients, watch yourself for symptoms of disease activity for the first month or 2 post-vaccine. But other than that, vaccine seems safe. These occurrences of uveitis or other autoimmune diseases post-vaccination occur. What the association is, unclear. What we do know is it's very rare. There have been for example, a case of sarcoid uveitis following zoster vaccine, but they're all case reports. So again, advice to patients, keep stable on your disease, make sure you're not having an exacerbation, probably then okay to get vaccinated, but watch yourself for a couple months post-vaccine.
Great. While we're talking about infections, Dr. Chironis brought up the issue of evaluation of anterior uveitis. We always want to distinguish between non-infectious and infectious forms of uveitis. Probably the only laboratory test that I routinely get on all patients with uveitis are serologic tests to rule out syphilis, obviously because the treatment is so different than we would be doing for non-infectious uveitis. But another distinction that we often have to make is the distinction between non-infectious forms of anterior uveitis and herpetic disease. We know that herpes simplex virus, varicella zoster virus, and now CMV can cause chronic anterior uveitis. So a question comes up, what are the clues that you have an infectious form of anterior uveitis rather than a non-infectious form? And when would you do aqueous paracentesis for PCR testing to identify the presence of virus? So I'll see if Dr. Tsui has any thoughts about when you consider herpetic disease and when would you do PCR testing?
Thanks, Gary. That's a great question. I think that's something that comes up often in the clinical setting. For me, when I take a look at a patient that has anterior uveitis and I'm trying to determine if it's infectious etiology, I do take into account if it's a hypertensive anterior uveitis, with viral uveitis having higher intraocular pressures. I also take into account the appearance of the chorotic precipitates, mainly comparing the phenotype of or the appearance of the KPs compared to CMV versus HSV or VZV. CMV typically has sort of a coin-shaped pattern of KPs or a kind of circinate pattern of KPs versus the kind of small to medium-sized KPs seen in VZV or HSV uveitis. In patients that I have concern for infectious uveitis, I often offer them anterior chamber paracentesis so that we can get to identify the diagnostic or the infectious organism. Oftentimes, if the patient defers the paracentesis, I will start empiric valacyclovir or acyclovir to treat for HSV or VZV. And then if it's not responding appropriately, then I'll revisit the idea of a paracentesis to check for a CMV uveitis.
We're actually running short on time. It's amazing how fast time goes by. I want to be sure and leave enough time for audience questions if there are any, but I promised that we would get back to what are the indications for and duration of secondary prophylaxis with trimethoprim sulfamethoxazole or other drugs to prevent recurrences. And a couple of questions that Dr. Whitcup might want to address is, these studies were based on trials in Brazil where ocular toxoplasmosis appears to be substantially more severe than it is in other parts of the world, especially in the United States, but it is a problem in Europe. And so the questions are, who do you treat? How long do you treat? And what if the patient is sulfa allergic? So, Scott?
So I think it's a great question because it's very practical. And we're fortunate in the case of the study by Felix et al. Out of Brazil to actually have randomized controlled data. So often in uveitis, we're basing our recommendations on our own practices or case series. Here there was a study that showed that following treatment of an acute episode of ocular toxoplasmosis, that prophylaxis for about a year prevented long-term recurrence. For 6 months, prevented long-term recurrence. And it wasn't even close. It was, near zero to about a quarter to a third of patients having recurrences. What makes it a little bit more difficult, the vision wasn't very different at the end of the study. The treated patients only had a couple letters better acuity. So my approach has been, there's still a burden of having to follow patients, worrying about the recurrence. They still needed to come into the office and get treated for exacerbations. So I do think that prophylaxis treatment after an acute episode for at least 6 months makes sense. It just decreases the chance of recurrence, especially in patients with macular lesions, where you're worried that some of those patients may have a vision threatening disease. Even though the visual acuity wasn't statistically significantly better, there was a trend for better vision. And my guess is in the subset of patients with lesions close to the macula, you'd even be more apt to treat that. As Gary said, you get side effects with these drugs, and a lot of patients are sulfa-allergic. Fortunately, there are a host of other antibiotics that you can use. Oftentimes in those patients, you want to talk to the infectious disease experts to pick the drug for that patient and a regimen. But we're fortunate that mostly out of Brazil, there have been other newer antibiotics that have been shown to be very effective. And maybe Edmund or Gary want to talk about what they use as well.
I completely, sorry, go ahead.
No,
I completely agree with.
You go ahead.
Okay. I completely agree with what Scott was saying in terms of if a patient has macular involving disease, prophylaxis is definitely my preference so that we can prevent any future recurrence. And as the trial showed, approximately 1 year of the prophylaxis had a nice durable response over that period of follow-up. In patients that are allergic to sulfa or have an intolerance to it, I usually go to either azithromycin or oral clindamycin, keeping in mind that some of these other antibiotics can cause some gastrointestinal side effects. So those patients are kind of counseled appropriately as well too.
Okay, I want to turn the program back to Dr. Chironis. We didn't get to all of these questions. I would be happy to hear from anyone if the meeting organizers want to distribute my email address, and I'd be happy to pass them on to Drs. Tsui and Whitcup if there are questions specifically for them on any of these topics. But
Gary, thank you very much, and thanks the panel for this exciting discussion. We do have some time. Actually, I do have some questions from our Greek audience. Bear in mind that many of us, comprehensive ophthalmologists, so we have a lot of questions regarding cataract surgery. There was some interest regarding cataract surgery in patients with uveitis, and in particular, I have a couple of questions here. One from Dr. Moutos, who wanted briefly for one of you guys to mention what are the prerequisites for safe cataract surgery in a uveitis patient. Just bullets, a couple of key points to highlight. And actually a very similar question by Dr. Philippopoulos is which is the most important factor in getting a good outcome? Is it the length of remission? Is it specific disease entity of uveitis? Is it surgical skills? Is it some kind of other, perioperative management? If we could please highlight this, because it seems to be a lot of interest in cataract surgery in uveitis.
Oh, there's so much we could say about that,
right.
But briefly, I think overwhelmingly the most important factor is good control of inflammation before undertaking surgery. There have been some studies that indicate that the risk of postoperative CME, for example, is decreased if patients have had well-controlled inflammation with corticosteroids or immunomodulatory therapy. As a rule of thumb, we say 3 months of best level of control on a stable medical regimen. As far as technique goes, well, let me backtrack for a second. The real concern is doing surgery on patients that have anterior uveitis or intermediate uveitis because of the risk of postoperative adhesions to the capsular remnants, or membrane formation or deposits on an IOL optic, as well as CME. There's less concern about people who have posterior uveitis, conditions like birdshot chorioretinopathy, or patients with inactive toxoplasmic retinochoroiditis. So it's really the anterior uveitis patients. As far as surgical technique goes, you know, decades ago when I was in training, we never put IOLs in patients, but implantation of an IOL is almost universal, even among uveitis patients now. But key is how to manage pupillary membranes, posterior synechia, and you want to manipulate tissues as little as possible because tissue manipulation will stimulate more inflammation. So one of the issues that I addressed many years ago was the problem of how to manage synechia so that you have a reactive pupil, and how to prevent postoperative adhesions between the iris and the remnants of the lens capsule. The way I manage the pupillary, the pupil is I will make small sphincterotomies in the pupillary margin with greasehopper scissors, for example, but not so big that it cuts through the sphincter muscles entirely. I think that that's far better than excessive stretching of a small pupil, which may result in a flaccid, irregular pupil. And then more controversial has been our recommendation to implant the IOL into the ciliary sulcus rather than into the capsular bag, because that allows the optic to serve as a physical barrier between the iris and the remnants of the lens capsule. Back when we first proposed this, it was considered heresy because you didn't want to have plastic touching the uveal tissue. I think that's less of a problem. I don't think that it substantially increases inflammation, but it certainly reduces the risk of postoperative adhesions. I don't advocate that for everyone. I only advocate that for people that have severe iris damage pre-op. That is not a universal recommendation, and there may be people in the audience that disagree with that approach, but those are some of the issues that I have considered important. And then final comment from me, and we'll see what the others think. Close postoperative monitoring is really critical. Your patients are more likely to have a higher level of postoperative inflammation than your general surgical cases. But if you manage that inflammation aggressively, it's very, it's relatively uncommon to have a poor outcome. So do either of the two of you have other ideas?
Yeah, I'll just make one quick comment and let Edmund comment as well, since he's operating on a lot of the uveitis patients. I just want to echo what Gary said about controlling the inflammation. That to me is the number one take home. I think the 3-month has been sort of the dogma, but it's stood up to the test of time. So optimal control of inflammation for 3 months. And to that point, you know, a lot of times patients who got into trouble, they were seen by the ophthalmologist maybe a couple weeks before the surgery and they looked okay. You really need to see them pretty close. I like to say within a day, if you could, of the surgery. And if you see inflammation, even if it's a little bit, postpone the surgery. And then, as Gary said, follow them closely post-op as well.
Yeah, I echo both Scott and Gary's opinions on cataract surgery for these patients. You know, 3-month rule of thumb is generally what we follow as well too. And for some of the patients that have anterior uveitis that's been controlled with topical steroids, I do advocate for them to start a regimen of preoperative topical steroids about 3 days beforehand, either with diphenhydramine, Durezol, or just Predforte. For patients that have a requirement of systemic immunosuppressants for their anterior uveitis or intermediate uveitis, I do recommend that they go on 1 milligram per kilogram of oral prednisone 3 days beforehand and have a taper about every 2 to 3 days after surgery. And that's, kind of an anecdotal experience as well too, just to really minimize the amount of inflammation post-operatively for these patients.
Thank you.
Yeah, and getting back to that big data study that Jennifer Thorne was doing at Wilmer, that may identify other risk factors or treatment strategies that decrease the risk of adverse events. So you can look forward to that coming out in the literature at some point in the future, and that may improve outcomes even more.
Excellent.
So, Dr. Chironis,
yes,
other
perhaps,
questions?
One last question. Given, and Dr. Tsui touched upon this, especially in the pandemic, we were thinking about, extended local options for treatment of uveitis. Unfortunately for us in Greece, our only extended, quote unquote, local option is the Dexamethasone implant. We do not have access to longer extended, steroids, the Retisert or the newer fluocinolone implant. So given that you guys obviously do have access and perhaps you have been using it, obviously with the MUST trial 5 and 7 year outcomes, I was wondering what's your take on, let's say, the newer fluocinolone implant. Has this changed your practice? Have you been using it more? I know from Gary's practice back in my residency days, he wasn't that much into local treatment then, but I'm wondering what's your take on that, because we do not have clinical access to that. Whatever is just from the literature, so I was wondering from you guys, what's your take on that?
Yeah, sorry, go ahead.
Well, I'll just say, Alex, you're absolutely right. I have never been a huge fan of the Retisert implant. It certainly controls inflammation very well, but it expires after 30 months and you've got that piece of hardware in your eye. We've had patients where the plastic pellet has dissociated and they've needed additional surgery. So that device I wasn't too keen on with my patients, although some of them did get it. It's always a balance between systemic side effects and local side effects, and getting back to the idea of patient quality of life and patient preferences, we have to let them weigh the risks and benefits and make a choice themselves. Now, as far as the newer implants, the Utique implant, I have I have a few patients who have received it, not many, so I don't have a lot of thoughts about it long term. It does also leave a little piece of plastic in the eye. Probably not the same level of risk as the Retisert fluocinolone implant. But I think Edmund had some thoughts, so I'll let him speak.
Yeah, just briefly on this topic. So with the dexamethasone implant, I think, during the pandemic, in the early days, of course, when we weren't sure if immunosuppression had a higher risk of poor outcomes or getting COVID, patients would potentially opt for more local treatments. But as we learn more about, immunosuppression and outcomes of COVID, I think we're more comfortable with, especially anti-TNF agents in these patients. Specifically regarding the fluocinolone YUTIQ implants, I think the way that I've used it is patients oftentimes get an Ozurdex as kind of like a bolus of steroids, similar to how you would start a patient on oral prednisone before going to systemic steroid-sparing medications. I would do this in a patient with an Ozurdex, and then later on potentially recommend a YUTIQ, because the amount of steroid that the fluocinolone implant releases is significantly lower than the dexamethasone implants. So that kind of acts as a basal continuous release of steroids. But for someone that has a large amount of vasculitis or significant amount of macular edema, I would opt for a dexamethasone implant first to get better control.
Excellent. Well, unfortunately, we're running out of time. Time flies fast. It's been a real pleasure and an honor to have you guys. I think it was the best uveitis update that we've had so far, and this is our fifth, the fifth time that we're organizing this meeting. So I want to thank you very much, you, Gary, Dr. Whitcup, Dr. Tsui. It's been a real pleasure. I wish you the best, and hopefully we'll have the chance to see you sometime here in Athens.
That would be great. That would be great.
Παρακαλώ.
And I want to reiterate my offer. Anyone who has questions, please give them my email address, and I'm happy to hear from any of you.
We certainly will. I certainly will. Thank you very much. Take care.
Thank you.
Okay.
Bye-bye.
Goodbye, everyone.
Bye-bye.